I'm arriving on scene. Scene safe. So he's going to give me my dispatch information. Be dispatched to the scene of a 23-year-old male involved in an ATV rollover. Okay. Scene safety BSI for myself and my partner. As I approach the scene, before I make contact with the patient, I'm going to do my general impression. What is the overall view of the scene? Where are we? What is the weather like? How many patients do I have? Is the patient conscious and alert? Are they following me with their eyes? Do I see any signs of like life-threatening bleeding or deformities as I approach the patient? Is there any civilians or bystanders standing around? Friends? Anybody could answer any questions? I'll call police, fire, or ALS as necessary. If you said I'm going to call ALS because my patient's whatever, if you say ALS in these scenarios, you're okay, because all your patients could warrant an ALS response. So he's going to give me that information. Remember, your patient is in a classroom on a floor. It's not real, so you've got to paint a picture. You've got to get an idea. If you want to go into a classroom with a notepad and a pen, you can. If you want to wear gloves and write the information on the back of your hand, you can do that too. All right? I don't want to see people spending time writing all this stuff down because you kill your time. But certain things you can make note of. All right, so I arrive on scene. I'm going to make contact with my patient. First thing I'm going to do is have my partner take manual, inline, neutral stabilization of the head. And I check for level of consciousness of my patient. Sir, can you hear me? We'll say my patient is unresponsive. All right? Patient is unresponsive. So the next thing I'm going to do is see if I can get a response out of him. I'm going to elicit a painful response, whether it be pinch the ear or do a axillary squeeze or a thenar pinch or a nail bed pressure. Mr. Examiner, is he responsive? And he'll tell me whether he is or not. We'll say that the patient is unresponsive at this point. So now I'm going to open the airway. How am I going to open it?
Jaw thrust.
Modified jaw thrust. Put your fingers in the right place. Make it look like you're doing it. Just don't really do it. Fingers on the jawline, thumbs on the zygoma, and I'm going to listen. Look, listen, and feel. Mr. Examiner, what am I getting for respiratory rate? And he's going to tell you, am I getting full chest rates? 6 in shallow, or 8 in full breaths, or 3 in shallow, whatever you get. Remember to put the proper administration set on the patient. If the patient is in respiratory depression, we're going to bag him. Anytime he says shallow, bag him. If the patient's taking 10 breaths or 12 breaths per minute for full chest rise, I can put him on a non-rebreather. Non-rebreather is a patient who needs oxygenation. A BVM is for a patient who needs oxygenation and assist with ventilation. You can never go wrong by bagging your patient. If you had a conscious alert patient who said, I'm going to bag my patient because you weren't sure, you're technically not wrong. You can do that. The examiner will look at you and go, are you sure that's what you want to do? If you said yes, he can't fault you for it. You can do it. So anyway, because my patient is breathing depressed rate of 8 shallow, I'm going to have my partner ventilate this patient, 15 liters high flow O2 by BVM at a rate of 10 to 12 breaths per minute, ensuring we have full chest rise, right? Okay. Next thing I'm going to do is I'm going to fillet the clothes, expose the chest. I'm not filleting the chest, I'm filleting the clothes. I'm going to look, Mr. Examiner, remember IPA, inspect, palpate, and auscultate. I'm looking at the chest. Do I see any life-threatening injuries? If I see something like a penetrating chest wound or something, I'm going to treat it right then and there. What would I do if I saw a flailed chest? Paradoxical motion.
Fix it.
How do I fix it?
Bag
What am I doing?
bag.
So I'm good. So next thing I'm going to do is after I've inspected, now Mr. Examiner, I'm going to palpate. I'm going to start at the opposite side. I'm going to work my way down and around and reach my hand underneath. Mr. Examiner, do I feel anything or see anything? If you see something, he's going to tell you. He can't hide it. He can't trick you. It's not a trick. If you touch something or look at something, he's going to tell you if something's there. I'm going to start at this side, work my way around, underneath. Do I see any life-threatening injuries or whatever the case may be? So there's my inspect, palpate, now I'm going to auscultate. Mr. Examiner, what am I getting for lung sounds? Put this stethoscope on like this and make it look like you're, put them in the right place. Don't just go, do the right thing. What am I getting for lung sounds, Mr. Examiner? Whatever he tells you. All right, now, My patient is unresponsive after a log roll or motor vehicle accident. Do I want to check the back? Absolutely. But can I log roll the patient?
No.
Not without a collar on. What you're going to say is, Mr. Examiner, now, due to my patient's condition, I want to assess the back for any life-threatening injuries to breathing. To do that, I must apply a collar before I log roll him. So I'm going to apply my collar now. Just explain why you put the collar on. Mr. Examiner, I'm going to check the neck for tracheal deviation by palpation. We don't inspect it, we palpate that, tracheal deviation. I'm going to inspect for JVD, and I'm going to check the back of the neck for any step-offs or crepitus. Anything noted, Mr. Examiner? If there was, you tell me. I'm going to measure and apply a collar. My collar is on. See, I didn't pick it up. I just verbalized it, because you've already put on a collar at another station. Now, Mr. Examiner, I'm going to put this hand up. I'm going to use this arm as an anatomical splint. We're going to use as many people as we can. We're going to interlock arms. Person at the head is going to do the count. Ready? 1, 2, 3. Now, while the patient is up, Mr. Examiner, I'm going to inspect the back, looking for any life-threatening bleeding on the back and all the way down the backside. Any life-threatening bleeding, Mr. Examiner. I'm going to check the spine, and I'm going to listen to lung sounds. What am I getting for lung sounds, Mr. Examiner? If you found something like a penetrating wound or something like that, fix it. Put on the occlusive dressing. That's what we have it for. So once that's all done, I'm going to say to the examiner, now, Mr. Examiner, I'm going to log roll the patient back onto a backboard. Might as well put him on a backboard. I'm not going to log roll him again. So insert the backboard. Person at the head's count 1, 2, 3. Patient is now on the backboard. Now I'm going to check circulation. I'm going to check for a pulse, radial and carotid. If the patient's conscious, I'll just do a radial pulse. I'm also going to be looking at the skin. Mr. Examiner, what am I getting for skin, color, temperature, and condition? And he'll tell you, rapid thready pulse at the carotid, barely palpable at the wrist, cool, pale, clammy skin, or whatever he gives you. Now, Mr. Examiner, I'm going to make my transport decision. My patient is a high priority transport. Now, you can make that determination at any time. You don't have to do it now. But you can't say scene safety BSI, high priority transport. You have to do some assessment first. So my patient high priority transport, now I'm going to do my physical secondary survey, Mr. Examiner. I'm going to start at the head, and I'm going to look for DCAP BTLS, deformities, contusions, abrasions, punctures, perforations, burns, tenderness, lacerations, and swelling. If you don't tell him what it is, he's going to ask you. Know the mnemonic. Palpating the head, Mr. Examiner, do I see anything? I'm going to use my pen light. I'm going to shine light in the eyes. What am I getting for pupillary response? I'm going to look at the ears for bleeding or drainage. Do I see any? What happens if I get bleeding from the ears? What am I going to do? Halo test. I'm going to dab a 2x2 on the ear, and I'm going to put it off to the side. Then I might dress the wounds lightly or dress the ears lightly. Watch for that. If it produces that halo ring around the blood spot, that's positive for cerebrospinal fluid. I'm going to look inside the nose, inside the mouth. I'm going to ask the examiner, Mr. Examiner, as my patient is being ventilated, is my patient being ventilated well? Does my partner have good compliance with the bag? Is it getting harder to bag the patient? If it was getting harder to bag the patient, what would that be telling me? A developing what? Pneumothorax, right? So it's important to know. So, Mr. Examiner, how is my patient being ventilated at this point? If my patient's breathing, then I'm going to say, Mr. Examiner, I have a non-rebreather on. How is my patient breathing at this point? Right? I'm checking. I'm going to check for tracheal deviation by palpation and JVD through the collar, because the collar is on. I'm going to start at this side. I'm going to assess. I'm going to look, inspect the chest. Did I see anything? Did I miss anything? I'm going to work my way down, around, and underneath. I'm going to do the same thing on the other side, down and underneath. Mr. Examiner, anything during palpation? Listen to lung sounds again. Mr. Examiner, what am I getting for lung sounds again? Just repeating it. I'm going to check the 4 quadrants of the abdomen, looking for distension, rigidity, and rebound tenderness. 2, 3, and 4.
I know, that's the way people don't want that.
What's that?
It doesn't feel good.
I know, it doesn't. It sucks. That's why you see you're awake, you're conscious now. You didn't like it. So I'm going to check for rebound, tenderness, distension, rigidity. Mr. Examiner, did I find anything? And he's going to tell you. Next thing I'm gonna tell, now, is there anything we can do with the abdomen? Distension, rigidity? No, noted, it's noted. I'm gonna push down and in, or in and down with the pelvis. Is it stable? If it's not stable, he's on the backboard. Is there anything else we can do? Probably not at this point. I'm gonna check for bleeding or drainage in a priapism in a male, bleeding or drainage in a female. Mr. Examiner, anything noted? He'll tell you. I'm gonna do an offhand assessment. Offhand means I'm not gonna grab the leg like this. I'm gonna do offhand so I can see if there's some form of a, fracture. Work my way down, squeezing, checking for distal pulse. If he's conscious, I can do CSMs. If not, I'm just checking for a pulse. Mr. Examiner, what do I have on that extremity? You're gonna do the same thing on this extremity, all the way down. If he told you that the patient had an open tib-fib fracture, don't do this. Note it. Okay, Mr. Examiner, noted on the left-hand side, open tib-fib fracture, right? If you see life-threatening bleeding, fix it immediately. The moment you recognize it, stop the life-threatening bleeding. If it's just oozing, then note it. I'll address it later. I'm gonna work on this arm, doing an offhand technique, work my way down, check for pulse, skin. Do CSMs if he's conscious. Same on this side. Now, I'm going to reach underneath the patient to check the posterior lumbar, thorax, and buttocks region. Already checked it when he was log rolled, Mr. Examiner. I'm going to check it again. Reach under and pull your hands out. Anything I missed? No. Now my patient's on the backboard. Next thing I'm going to do is a sample history. Is there anybody around who can give me any information? Most of the time, the examiner is going to tell you no, because you're going to do your sample during medical trauma. He doesn't want to sit there and listen to you again. He's going to have 20 people to have to listen to. So he's going to say, no, there's nobody around. So I'm going to say, okay, Mr. Examiner, if there's somebody happens to be there who can answer questions, run through your sample history. Signs and symptoms, allergy medications, ask the questions. Next thing I'm going to do is a complete set of vital signs. Mr. Examiner, what is the patient's blood pressure? What is their pulse? Rate, rhythm, and quality. What is their respirations? Rate, rhythm, and quality and depth, including lung sounds. If I'm ventilating for them, are they trying to breathe around it? What are their pupillary response? What is their level of consciousness? Right? Get all the vital signs. If you got a pulse at the beginning, and you ask the vital signs again, or you need to know something, ask. The examiner will give it to you. It's not like, oh my God, you forgot the vital signs, you failed. It's all right, because you can take them again in real life. So if you ask him what the pulse was, he'll give it to you. Ask a question. After that, after I take my vital signs, I'm going to treat any secondary injuries that I found. Whatever you found that you didn't fix already, fix it now. Dressing. As far as splinting, if you have upper extremity splinting, you can do that, but the lower extremity, they're on the board anyway. Wouldn't bother with it. Small wounds, you can bandage and stuff like that. Then you can say, I'll do a detailed physical examination as time allows, en route to the hospital, and then I will constantly reassess my patient. Vital signs every 5 minutes as he's unstable. Any questions on that? Ross?